Live from the Glasgow Electric Plant Board, Glasgow Wants to Know. With your host, Mr. Uhel Barrickman.
Good evening. Our subject tonight is the health problems and what to do about them. We have seen much in the news media recently about the nature of the problems, its causes, and what to do about them. And it seems that no one can agree what to do. Tonight we have three members of our panel who are familiar with the problems, and I hope some of them have some ideas about how to solve them. They are Dr. John Asriel, a family practitioner here in Glasgow, John Bennett, a pharmacist with Ely Drugs, and Steve Brown, who is with the Barron County Health Care Center dealing with the aged. I think we can all admit that there are problems. Some people call it a crisis, and I think we can admit that the two major causes of the problem are the high cost of medicine and health care at this time, and the fact that there are quite a number of people who cannot afford insurance to cover the cost. And I'll start with you, Doctor. What, from your standpoint, are the chief causes of the cost?
Well, I think the main thing that's happened to raise cost has been, over the last 40 years or so, the development of people besides the person receiving the health care paying the bill, as we've got to be what we call third-party payers, whether it's Medicaid or Medicare or insurance companies. When someone else is paying the bill and the patient is not, or the person receiving it's not directly responsible, it's made for the cost just to rise and rise to the highest level of that third party would pay. And then the other thing that happens is that we've not been, again, partly because it's a third party payer who's not directly there having to say about it, with not been any limits placed on how much health care is provided. You know, different tests and interventions. There's been very little reason for physicians to limit what tests are ordered or what interventions are done, so long as the family and patient are willing, since there's no real financial reason not to now. The price just gets deferred on the third-party payers.
Mr. Bennett, why have drug costs gone up?
Well, it goes back to manufacturing. I feel like this is the place it needs to start, talking about pricing of medications. It used to be the manufacturer was interested in the health care it was giving. The old companies, Eli Lilly, Merck Sharp and Dohme, Park Davis, these companies were interested in just what they could give. Now they're more interested in the bottom line, and as all manufacturing has. It's just not the medical profession, but it seems to me that now it's whatever the market will allow, that's what we'll charge. And it's just getting out of hand. And unless we can put a stop to this, and I feel that the only way this is going to be done is through government intervention in this particular area.
Steve, in your profession, in your capacity, you're dealing with large numbers of people who really can't afford the care that they receive and what you have to give them, and somebody else is having to pay for it. What has brought that about from your standpoint?
Well, that's has came about just simply due to the fact that the population is living longer and longer today, and when someone retired at age 62 or 65, they may have had several dollars in resources at that particular time. But when you look at the average age in a nursing care facility of our type is is 85 years old, and over a period of 20 years with what inflation has been in the last 20 years, it soon eats up those individuals' resources, and they get to the point that they don't have the resources necessarily to pay their own way, but yet they need the service. And there again, the two programs of Medicare and Medicaid are actually paying for those services, and you know, they within themselves set certain standards, and for facilities to meet those standards, it becomes extremely costly in order to make sure that all those standards are being provided to all the individuals that are receiving the service in the facilities.
Well, within the last 8 to 10 years, the costs, though, have been far outrunning the increase in inflation. How do you explain that?
Well, I think in our particular business, it's simply due to the fact that the regulatory process within itself, the government sets certain standards, and over the last 10 years, those standards have been added to on 3 different occasions. And to give you an example, 3 years ago, when the new OBRA laws came into effect that we all deal with in our business, where we received an additional 500 regulations, we still have not been able to absorb all that cost within the system at this point in time. But so far, that's added about an average of $35 a patient day in this state alone, and it's still rising, and it's extremely expensive. I'm not saying that all the regulations were not necessary, but what I am saying is that many times Congress passes numerous regulations which usually the public wants, but it becomes very costly to end up trying to implement those regulations nationwide.
Doctor, we'll get back to you. He is implying, to say the least, that some of the paperwork that's required by the government is creating a problem and adding to the cost. How's that affecting cost in your profession?
Well, I think it directly affects cost in that it takes a lot of people and employees to file that. We find that just the burden of doing the paperwork and filing charges and such takes a lot of people these days, and you have to hit all the government codes that the I's have to be dotted properly and so forth, and it just takes a lot of people. Indirectly, it also increases costs because we know that you have to have everything the government wants in patient care, whether or not you always really need it for patient care. You got to have it for review, and so that increased costs because you may have to keep a patient around an extra day, or you may have to do this or that in order to make sure that you do everything that you know will be wanted to be seen on the paper later on. So it increased costs in several ways, I think.
John, Mr. Bennett, we got 3 Johns here, so I better be careful. But what have you seen by way of government regulations in the drug industry in the last 10 years that has increased costs from the standpoint of drugs?
Well, just starting out with a new product it costs millions and millions of dollars to get a really new product on the market. It takes time. If you saw the other night, they were talking about, on 60 Minutes, I think, on a rerun, they were talking about some AIDS drugs. And getting these drugs out, the time that it takes to get these out, plus the money that it takes. And anymore, the drug companies aren't even willing to go for this thing because most of these people don't have the money to pay for it. Gets down to money again. After it gets through manufacturing and gets into the drugstore, we have one regulation right after another. Everything has to be dotted. Everything has to be redone. We have Medicaid, particularly in the state of Kentucky, it's big as far as in the drugstore. All this has to be sent to Frankfurt, and all this, about half of it comes back to you as wrong, missent, etc. There's always something going all the time. More people, more computer time, all this has to be taken care of.
Do you find, Doctor, that you have many people or few people, because of the government assistance now, that come to see a doctor when really there's no need for it.
Well, the government assistance certainly changed that. I think the place we see that most is in the emergency room, where people don't have a lot of incentive to learn that they don't have to go to the emergency room for every complaint, for every cold or every child with a diarrhea or every bump. They don't have to go in. When they can go in, be seen, and be taken care of any hour of the night and not have any bill from it, there's just very little reason for a patient who's on some government assistance not to do that. So I think and the emergency room is a very high cost place. So I think we see that a lot more in the emergency room than we do in our office. We have certainly people on government assistance use offices more too, but that's probably more appropriate than the use of the emergency room, I would think.
Well, now you raise a question in my mind. Why is it that your profession is now sending more and more people to the emergency room for things you used to take care of in your office? And I think that's true. I've observed it.
I think that is true on some things. I think it's become easier to get some things done in the emergency room. Like we have some, and also along with that, it's become sort of more standard that with somebody, a patient, that they're going to have more things done to them. So if you have somebody who is, say, old and infirm and it's simply hard to move around, it's going to be hard to get blood tests, it's going to be hard to get them the x-ray. You're not going to be able to do those things very well through your office, and it's just very much easier to do it through the emergency room. So that a lot of that's done for convenience, or to some degree they're going to get checked out better because it's so difficult to handle some patients in the emergency room because of those technical aspects. Again, part of that change is patient expectations. They're going to have x-rays done, or they're going to have blood tests done, or things that may be more easily done in the emergency room.
Am I understanding you to say that a lot of the patients themselves are requesting that they go to the emergency room for those tests?
Well, we do have patients request to go to the emergency room. Yeah, and with this, you're talking about the medical assistance program with what they call a KIMPAC program, which is a Medicaid program. They have to have the doctor's approval to go over there. And so we get a lot of calls for patients who just simply have shown up at the emergency room, and we have to say, no, send them over to the office instead if we think we can handle it there. But if it's something that's going to be time consuming or something that's going to require a fair amount of testing, we know it would be maybe more easily handled there. I say, generally speaking, I don't say requesting tests for it, but there's an expectation of people that if they fall and sprain an ankle that it will be x-rayed, an expectation that if you're feeling tired that you'll get some blood tests done. And a lot of folks just recognize that things will be maybe done more easily in the emergency room, at least if they're, say if they can't walk or they're stretchers, know it may be simpler to go to the ER. That's not always true, and we try to handle a whole lot through the office.
Well, I gather from some statements that you made in the beginning that you think that if each patient had to pay at least a part of the bill, that it would solve some of the problems of demanding and receiving certain tests and procedures that really aren't necessary. Is that one of the things that tying what you just said into what you said in the beginning is?
I think that economics need to be part of a patient's consideration whether they want something done or not. Right now it does not have to be. I mean, if a patient comes to my office and says I have headaches and I want to get checked out completely, then they don't have to judge finances for whether they want a CT scan of the head done or all kinds of other expensive tests. They don't have to think about the cost of it. While it's not practical right now for any of us to bear the full burden of the cost individually, we have to spread it out through society in some form. I think that each patient and each family should have have to consider finances to some degree with each decision. That might make some difference for a lot of things.
Well, let's take the average patient Are there tests usually performed today on the average patient that's not necessary?
Yes. That comes down to definition. That comes down to what is necessary, which we get to talk about you lawyers to go with things. It depends on.
Let me rephrase it. From a medical standpoint, are there tests being done today on the average patient? Not always, but I'm talking about on the average patient. Are there tests being done today that are not medically necessary?
The thing is, it depends on how much certainty you want to have on things, and that's the point. And part of that comes, back to meeting patient expectations and fear of malpractice and those things. But we can very often be 95% sure of something without a test. But we say, well, is that good enough? We got to have a test for this. Then we'll be 98% sure. So for small gains in certainty, you get into some pretty expensive testing. Back to headaches, for instance, I can be pretty sure in my own mind that a patient does not have anything that's going to show up wrong with a CT scan. But I have no real reason to take that chance, if that maybe, even though it may be only a 1 out of 1,000 chance, if since it doesn't cost me anything to do it, and it doesn't cost the patient anything to do it. So I have no reason not to gain that very small increase in certainty by ordering that test when the patient wants it anyway and he doesn't have to pay.
Now, you said it doesn't cost the patient and doesn't cost you anything. Does it gain you anything?
Well, in that situation, it gains you a reassured patient who feels comfortable they've been checked out and that there's not a brain tumor or so, and then you can talk about other things that cause headache. Now, reasonably, we could have done that anyway if without that, I mean, most of the time, and most of our CT scans of the head for headaches are normal. But I say for small increases in certainty with a diagnosis, you pay an expensive price with money.
Barrickman, in saying what John said here, you do 100 scan tests, cost $1,000 a piece. That's $100,000. You do 100 of them, you get one test where you find something. You're able to work on that one patient, save the man's life. Now, is it worth $100,000 across the board to do 100 people to find that one? If you were the one, you'd say that was the right thing to do.
That's part of what they're talking about some when they're talking about statewide health care reform. They talk about standards of practice. In some degree, we're almost afraid not to order the test, because that, even no one, again, I'm picking on CT scans and headaches. Nobody has ever shown that the CT scan is an effective tool for headaches, at least cost-effective wise. I mean, the amount of things you find with that when you're working on headaches that are surprises and are treatable are very, it's pretty rare. But no one is willing to take the chance for individual patients saying, no, you just plain don't need a CT scan. The chance of finding something is too small. Now, perhaps the standard of practice that says, headaches headaches without other findings do not require a CT scan might take a little bit of that off us, where you can say, the standard of practice of this does not include any further tests. Your insurance will not pay for it if you have it, and so if you have, I'll get it if you want us to order it, I will, but you'll end up with a bill. Perhaps that would change things, and also the freedom of knowing that that you're not going to have a burden of malpractice on you for not getting that test done. Right? To some degree, doctors are scared of that.
Steve, insofar as nursing homes are concerned, and I understand that you are not a doctor, but you're certainly dealing with a lot of medical patients. Is there any truth to, based on your observations and to what you commonly hear, that many of your older people, both in and out of nursing homes, are overly medicated?
There's been some national studies done that shows that that is true in certain locations of the country. Speaking for our particular area, I will say that's not the case. And the reason I say that is not because necessarily Dr. Asriel is sitting here, but the medical community in this community, at least with the individuals that I can speak of within the institutional setting, has always been, I think, very conscientious of trying not to give individuals too much medication. And you know, when the law changed in that particular area a couple of years ago, on the federal level, where that now all these psychotropic drugs have to be reviewed automatically now every 60 days, and if certain dosage, there has to be clinical cause for that and that type of thing. I think that it improved that situation at least a great deal in the institutional setting. But and I think that's true nationwide, because there's already been some studies printed as recent as 6 months ago showing that there has been a tremendous change in that. But in this particular area, I think that it's always been pretty common that physicians have not and facilities have not encouraged individuals to be over-medicated, that we feel like it's important that people have as much freedom as possible, because it means that there's still some potential there for those individuals that can for rehab and still a certain amount of quality of life, and I think that's extremely important.
Do you have people that would be better off if they were at home, provided there was some system to give them partial care?
I think that in every institutional setting you have a certain amount of that. I know in Governor Jones's plan that he submitted, he came up with kind of a new layer within the healthcare system called foster care. There's a certain number of individuals in every facility, and it's a small percentage, maybe 5% as an example, that if they had more family support, that type of thing, they still could probably function in a home type setting for some period of time. With the great majority of our residents, that's not necessarily true, but there's a certain percentage that could, but due to the fact that they don't have necessarily the family support. Home health is a good concept and provides a lot of good professional expertise for families that have the capabilities to be able to stay at home and assist their family members. But here again, you still got to have someone to deliver a lot of that hands-on care, and in many instances anymore, you have sons and daughters that were born and raised in Glasgow, but yet have moved counties and many times states away because of the economic situation. So you have mother and father back home that's not always able to provide that type of service that needs to be provided on a hands-on basis day after day.
The average nursing home patient now takes a lot more care than
That's
30
right.
years ago.
Sure, because your acuity level is so much higher. I mean, the things that we do for the nursing home patients today, you know, they're so much sicker. I mean, we're talking about a lot of individuals today that just about all their ADLs for their activities of daily living speak of has to be totally cared for by someone, and you know, they're between their medication and their general overall condition, constant lab work has to be done. You're looking at more and more individuals that have to have intermittent type IVs, you know, those type of things, and that within itself requires a certain amount of expertise that it means that they almost have to be in an institutional type setting anymore.
Well, now, so far we've been talking about costs and causes, and we've spent almost half of the time here on that. Let's get into the area of what, if anything, can be done to control it or remedy it. And again, I'll start with you, Doctor. One reason is I heard you make a talk at Rotary on the subject. I think the public would be interested in your views.
Okay. Well, one thing is, when we've already touched on this, I think every patient and family have to have a reason to think about cost. Doesn't mean they have to be, you know, have the full cost directly on the patient and family, but I think there has to be some cost that goes along with every decision. You know, if you want to have a test, you're going to have surgery, it can't just all be pushed on the third-party payers. I think another thing is that we need to, I also mentioned the standards of care we're talking about, or we need to have some more guidelines for healthcare providers as to what it is acceptable, really basically what's acceptable not to do. Let's say for this problem, you do not have to have this whole battery of tests, for, you know, so where it gives us a little bit more ability to deal with the patient and family, and saying, you know, it's really not standard to do those tests for this situation. A big thing that in the long run, and I don't think we're ready to deal with this yet, but in society, something that's going to make a big difference along the way is when we're willing to accept letting people pass away without fighting it so hard. When someone has a terminal illness, or when someone is approaching that, for family and physicians and societies in general to be able to say, well, this is the point where if the patient's agreeable, where we need to be backing off and not doing so much, because a lot of the costs of medicine end up coming at the very end of a person's life.
From the pharmaceutical standpoint, Mr. Bennett, what's your solution in controlling some of the cost?
Well, I know as a pharmacist filling prescriptions for Medicaid, I find that if a patient has 3 or 4 prescriptions and one of those 3 or 4 is not covered, the patient doesn't get it at all, which can be really rough in some cases, can be the most important one of the 4 prescriptions that the patient needs. I believe, like Dr. Asriel said, that there need to be a cost accounting when we're talking Medicaid, that the patient should have to saddle some of the financial burden. In some states, and each state is operated differently, each state operates its own federal Medicaid along its own lines, just governed by the federal government also. And in some states they have a copay, a $2 copay, which would go a long way financially in making them aware of what they're getting. I think that in the long run, as far as the pharmaceuticals go, that the federal government's going to have to come in and help us. I wish that we could solve it ourselves. I don't think that Governor Jones can solve it. I don't think it can be done on a state level. It's going to have to be done on a federal level. I feel that they're going to have to take that active front row type of look at this thing, and they're going to have to put aside the lobbyists and all the money and make some hard decisions that probably the voters won't like.
So, excuse me, go ahead, Doctor.
I was going to say, let me throw in for perspective here. I agree with John. I think it is going to take some intervention now, and we're at the point of needing that. And I think that's one thing that all of us can agree on, and everybody will agree on generally, that something has to be done at this point, which is what you opened the program by saying. As a matter of perspective, let me just mention it here locally, for instance. Things are at the point now where companies can hardly afford insurance for patients. For that reason, we see things such as most of the companies now hiring their new people here in town through a temporary agency. And the simple reason for that is they can't afford the benefits, which is workman's comp and health insurance. It's not that they can't afford their salary, but they can't afford the benefits. So what happens from that is that everybody suffers. The employee gets a lower wage. They also get, they're also without insurance, so they don't have access to the health care system. That's probably going to get worse and worse, and the whole driving force behind that is the cost of health care. That's a whole lot of it. So we're at the point where something has to be done, and it's not just directly so that people can get their illness taken care of. It affects everything. It affects your job. It affects the deficit that we hear about all the time. It affects so many things, and so it has to be taken care of.
What is an example of what you were talking about there? It's been a year or so ago that I knew of a family of husband and wife and 2 children, and their insurance was costing them between $400 and $500, over $400 a month. And there's all kinds of people in this area that cannot afford that.
And
they're still not paupers.
And they probably can't even get insurance if they go and apply and try to get it themselves. You have to work somewhere to have it, and then you can't really risk losing that job because you'll lose your insurance. So it ties people down where they might not otherwise be tied down. They can't, if they have any sort of illness at all, they can't just simply go out and apply and get an insurance. So, and again, it all comes, it's not the insurance company's fault. They can't afford it because they know things would cost so much. So the whole cost cycle is just so far out of control.
Yeah, I think it gets back to what Dr. Asriel spoke of earlier a little bit about expectations. You know, several years ago, I was on a certificate of need board for 4 years, and you know, individuals that wanted to provide a new service or expand their services came before that board and presented their case, and we made a decision one way or the other. And usually when we turned somebody down, it ended up in court, and 9 out of 10 times it ended up that the courts would rule in their favor. But we found, or I found in being in that position, that the expectations of individuals is extremely high of wanting the services. I don't want to pick on Bowling Green, but for instance in Bowling Green there's 2 major hospitals and they both have CAT scans. I think when I first was on the board there was about 4 or 5 in the state. There's more CAT scans in this state than there is in the whole country of Canada, as an example. But you know, it's become a state-of-the-art technology, and as Dr. Asriel spoke to earlier, when people get sick they kind of feel like that's something that they need to have done if you can't seem to resolve it real quick. And people, I'm not saying people's expectations has to lower, but I think people have to become realistic to the fact that those type of things are very expensive. It's a piece of technology that's extremely great, but it's also a very expensive piece of technology to purchase, a very expensive piece of technology to operate, and we can't necessarily have it in every community, as an example. And it's something that people, I think, long term are going to have to take a hard look at. And you're going to have to put some sort of system into place where the people have to make that choice, where that they actually realize that there is a certain amount of cost, and that, you know, we're going to have to absorb that cost through some way or other. And it's like Dr. Asriel said, it's not necessarily the insurance company's fault or the provider's fault. It's just a certain amount of cost that's out there that's as to what people expect, and due to that, it's extremely expensive. We've developed a system that's expensive.
One of the things we see with this reform is the movement to say, well, we'll pay the doctor less for doing this, or we'll pay the hospital less for doing this. But to make any real gains in holding down healthcare costs, we're going to have to simply have less things done. You got to have less services, which is what Steve is talking about there. It's not so much that CT scan or whatever, we keep picking on CT scans, but CT scans are going to have to cost less. There's simply going to have to be less of them done. And that's a hard message for society to take, because we're all great on saying, well, we want to improve access, we want to hold down costs. But when it comes to say we really want to change the system so there are less services rendered, then that gets hard. And that's what I have to see nationally when they talk about first having the basic health care package. I think they even changed their terminology because they realized that most of us didn't want a basic health care package, so they changed the wording around. But to be effective in the long run, we're going to have a way of doing less things, which means we have to be more selective in doing it, which gets back again to what you were saying at first, what is necessary. We're going to have a little bit more tolerance of uncertainty to be able to cut down on how many tests and procedures are done. And that's the only way to really save money in the long run.
You mentioned a while ago that we needed some guidelines, or at least the profession needed some guidelines along those lines. Who's going to provide the guidelines?
Well, I think it would be complicated, but I think it could be done by physicians with some push. Some of those things are almost in the medical literature, not quite. But it wouldn't take that much to study. I mean, keep coming at CT scan now. But it wouldn't take that much to study where CT scan saves lives and saves money. It wouldn't take that much to do that, to come up with a cost figure per life saved for headaches, for instance. And then, of course, there's always going to someone say, well, how much is a life worth? But the reality is, if you're spending the money, all that money for CT scans, you're taking it away from somewhere else. So, but you could come up with those figures and could make some judgments then about when are certain things necessary and when are they reasonable. For instance, with bypass surgery for heart, for many situations, we don't really know that saves lives. We don't really know that it prolongs working career, or that it really prevents pain that much compared to medical alternatives. In some cases, it's pretty clear, but there are a lot of people getting bypass surgery for what really is a gray area, things we don't know for sure. We know there's a blockage. It sort of seems obvious to us that if we get that blockage bypassed, they'll do better, but it's not so sure that it holds up with time and with studies. And I think it would be a reasonable thing for a government or an insurer to say, well, we're only going to pay at this for this health care plan, or we're only going to pay for things that we know are helpful. You know, I think there could be some guidelines like that.
Do you have, and we'll get deeper into this area right now by the question I'm going to ask you, and then lead from those. Do you have patients in the nursing homes now that are in essence vegetables?
Yes.
Yes, that's true. That's very true, Yo.
What percentage?
Well, there again, it gets back to the definition of what you determine as that, but probably within general concepts, probably at least 10%, 15% in some instances.
And
maybe.
Probably a fair amount more that, while not, you know, strictly vegetables,
Right.
are very, very low functional
Right.
levels.
You know, if you look at low functional levels and you expand it to that much, you may be looking as much as 25 to 30%.
And the next question is, each of those patients costs considerable more money to care for
Yes, sir.
than the other patients, even in your institution.
Yes, sir, they do.
Now, percentage-wise, again, can you give, I realize it's a guesstimate, but some
Well,
average there?
an average there, you know, looking at statewide, since all of our residents are evaluated every quarter, those numbers come out, we get a statewide average, but statewide average on the lower end of what's considered a high acuity level, we're probably looking at somewhere around 40% of the residents in the state are on that particular level. When you get
And
into
I guess all of you would agree that that significantly increases the cost
yes.
of care.
It's-
Not only, all up and down the line, it
Right.
increases the cost for everybody.
That's correct. And you also get in the thing, as Dr. Asriel was speaking of earlier, to a certain extent, that, you know, people kind of need to make choices about living wills. I know that's a difficult decision for people to arrive at, but it's getting to the point, I think, anymore that, you know, the longevity is extremely high in this country, and you know, sooner or later we are going to be stricken by some sort of major illness, and you know, people need to try and realize as to what they think is reasonable to be done when you start looking at the quality of life.
Those are really tough decisions. They're very hard, and to some degree we've been fortunate that finances have been spared from that. You know, as doctors and as families, we've not had to directly deal with the burden of what that costs, to say,
Right.
well, we can give your grandmother a feeding tube and maintain things, and we can treat with IV antibiotics when you get sick, and you know, we can do it however you think is best for your grandmother. And in some degree, it's always very difficult to deal with. It'd probably be even more difficult if we had to deal with, you know, but it's going to cost you. But realistically, from a society point of view, that question is going to have to be asked, and that's going to have to be a factor that's put in there somewhere.
How, if any of you have any information in this regard, how are those problems handled with, for instance, the Canadian system or the system in Germany? Any of you have any information about that?
I don't have any information on that. I honestly don't know.
I don't know. I'm not sure it's that much different, at least in Canada. My understanding is that most of the gains in the Canadian system have been from cutting back on the paperwork we talked about earlier. I'm not sure that they've handled that sort of ethical
Right.
question of how to apply their resources any more than we have. I don't know about Germany at all.
You know, basically the Canadian system cut back on the paperwork, and they basically, limited the services. They kind of eliminate a certain amount of duplication of service. They spread out certain services in certain regions, and that's it. They kind of got back from the way that we do it in this country, where that any large community that has a hospital tends to have just about all the state-of-the-art technology there. They limited the access to technology to just certain areas of the country. So that particular issue, I'm not so sure, like Dr. Asriel, that was ever really directly addressed.
But of course, according to what I have read and seen, we've got somewhat of a selective system in place here already, in that there are certain procedures, as I understand, that the medical profession normally won't do on some older people. In other words, you've got, for instance, liver transplants and things like that. I think I've seen where even the governor of Pennsylvania, where he had a liver and a heart transplant at the same time, and he was over age, and except for the fact he was governor, they wouldn't have done it. Is that common?
Well, I think when you get into, those very super specialized procedures like that, it certainly is. I mean, it's sort of makes, I guess, just sort of common sense to us that you're not going to recommend a liver transplant to someone who's 100 years old. I mean, just as far as allocation of resources, not that many livers around, and the life expectancy is so poor, and the immune system's so poor it's not likely to work anyway, and they probably wouldn't tolerate a big surgery. So I think it's just you can sort of almost eyeball those cases and see why that comes about. I don't think it is common for us to say, well, you're 65, you can't have a heart bypass. I don't think that. I think for more commonly done procedures, while age may be taken into account to some degree, I think much more it's taken into account what the patient's health status is. But when you get into transplants and such as that, yeah, I think it probably is, because they're getting this to where it's not just a matter of cost, it's a matter of just not having that many organs to go around and trying to get the most use they can out of them.
Particularly in transplants, even with transplants, with my understanding, even with younger individuals, they try to look at what the potential outcomes are to make sure that the patient is basically healthy otherwise, and that if this works, that the quality of life will be good for several years to come, because sometimes even in younger individuals they may not be in the best of health, and that will not always be recommended, as Dr. Asriel said, just due to the limited amount of access due to certain vital organs.
But for all the common procedures that we do here in town, for instance, or in most of our referral hospitals around, age alone is not going to keep somebody from getting anything done. It would have to be sick enough to think they should not have it done. Like if someone didn't think they could tolerate surgery, of course we'd recommend against it. But if they're healthy enough to tolerate it and it's the proper thing, then it'd be recommended regardless of age.
You have to look at the whole picture and just not one particular factor, so to speak.
Well, everything that you hear about the solution to the problem by the government contains something about controlling cost. But I don't see any, based on what I read and hear, I don't see any specifics as to how they're going to do that. How are you going to control cost? How can you control these costs?
I know in the pharmaceutical side of that, there's a lot that can be controlled if they wanted to. As I've talked before with other people about the generics against the brands. We have a major company that makes a drug that costs maybe $500, and the same thing approved by the government as being the exact same thing may cost $10. The same drug that costs $500 can be found somewhere else for $10 approved. So right there means that there's something wrong with our system. In the pharmaceutical side of this problem, I feel like that it's whatever the market will bear is what the price of drugs are. And you get the orphan drugs, the drugs that are made for just a small percentage of the population, a small, which even like AIDS, although in this community it's a small percentage right now. Those drugs have to be paid for, and they'll be sold just astronomical high, and the insurance companies, if the people have insurance, is going to have to pay it. Years ago, 30 years ago, the insurance companies were working on a percentage. And if the hospitals and the doctor's office and the pharmacy charged so much, they got a 0.5% over what they bill back to the companies that the employee works for. They got a 0.5%. Well, a 0.5% of $100,000 and a 0.5% of $1 million is quite a bit different. And so it didn't bother the insurance companies back then what was happening to the medical area of this country. But it snowballed and snowballed and snowballed and got larger and larger. And now it's at such a snowball, a landslide, that we can't stop it. And there's only one. The government is the only answer to stopping it. Now we can come up with a little this and a little that, but I feel like the government's going to have to come in and stop it.
Well, how's the government going to stop it?
All right, they can do it by first within the by decree. Yeah, so they can say we're going to stop this right now, and they can start by cost. They can run cost efficiency. They can find out what it costs to make these drugs that they're selling it. There isn't a week goes by that I don't put out a prescription for $300, and there's not a month goes by that I don't put out a prescription for $1,000. You know, fortunately, most of the time, third party pays paying for it. But I'm positive that $1,000 prescription's not costing but $100. I'll bet you less than that, but who knows? Only that company knows, and I think the government needs to know.
One thing the government is going to have to do in the big picture is they're going to have to demystify health care to some degree. Right now, health care is treated different than, say, construction or roads. If someone, say, it's sort of, when we base how much health care people get, we base and from a government standpoint, where they give money to pay for something, is based almost exclusively on, well, should they have that done or not? You know, should they have this health care rendered there? But it wouldn't be the same for roads. I mean, you couldn't make a case for, I really need a road bad, build it for me. They have to say, well, no, we've used our funds for roads for this year. And somewhere along the way, it's going to have to be some fiscal responsibility in the government's standpoint to actually try to allocate resources and to say, for health care, this is how much money we have. We'll spend it as well as we can, rather than what amounts to being a bottomless barrel. If we just reach down as far as we can to pay for as much as it seems like needs to be paid for. It needs to be treated like other resources in society, where they know more or less how much money is going to go into it, and spend that as well as you can do it, rather than paying for it until you run out of money. Yeah.
Steve, you have any ideas how to decrease costs or control costs in the
I tend to agree with John and John to a certain extent that unfortunately you got to have some entity that has the clout or the club, so to speak, to rein in cost and try to keep people in line. You know, in our particular industry, since we are so heavily government regulated, we're the second heaviest regulated industry in the United States, that there's a lot of things on paper that could be streamlined, that could be done a lot differently than what it's done to this point in time. Historically, when the nursing home industry has tried to lobby for some of those things in Washington, then the different advocate groups tend to always snowball and put a stop to it to a certain extent. But there's probably 15% of the regulations that's on the books today that could actually be done away with, that would not have any drastic effect whatsoever on the quality of care. Payment system, that's a system that could be streamlined and made a lot more equitable than what it is today, in order that facilities don't have to spend so much manpower and computer time in order to try to get those type of things taken care of, because it's extremely costly to do what we have to do today in those areas.
Well, it seems to me that all of you are in essence saying that we need two things, and I'll toss this out to see if this is fitting into your thinking. One, I would say, would be a regulatory body somewhat similar to the regulatory bodies that control utility costs. As all three of you know, being educated men, your electric rates and telephone rates and so forth are reviewed and set by a rate-making body, which they take testimony and evidence as to cost, and they figure in how much profit should be allowed them and so forth, and they even have private investors, of course, in the utility companies, and how much they should be allowed to make in order to protect the investors. Are you suggestion is that as one thing that's needed for health care? Or am I afield there? I sort of gather from what you're saying that
that might, for pharmaceuticals, that may make some sense.
Yes.
For drugs. For other things, like how much the hospital is going to charge for a service, or is a doctor going to charge for a service? And like I said earlier, I don't think it's really the price per service that drives health care so high. And that would make temporarily some difference. That might buy you some time, buy the government some time if they did that for a while. But the real thing, I think, is they've got to cut down on services. So I don't think it's going to be as much as of reviewing price per service as it is coming up with a way where actually are less services rendered without sacrificing what they call quality. Keeping people, cutting out the ones that, as you said earlier, are not necessary. So if we can come up with a way of doing that where there are less services rendered, then I think that'll make a big difference. And some things would do. I think
you noticed I said a moment ago, I thought from what y'all were saying we needed two bodies, one on rates. Now the other one is just exactly what that I had in mind, is just exactly what you're talking about, another body to control the services. Now my question is, who's going to do that and how are you going to manage that?
Well, I think to some degree it has to be the person who's paying the bill, whoever that is. Of course, that's all of us for most things. But the state would have some say in that because they're paying the Medicaid bills. The federal government would because they're paying the Medicare. And the insurance companies would because their subscribers eventually end up paying for people that have their insurance. And I think it would be reasonable to say we can give you a lower priced insurance plan, but it's not going to cover emergency rooms. Because emergency rooms take so much money and the return is so small. Or we're only going to cover emergency rooms for trauma or chest pain, say. We're not going to cover it for anything else. Most anything else can wait. And recognize there'll be some times when a patient does need to go and they will have to pay out of their pocket. We can't pay for everything, as far as a health care plan. And you can do the same thing by saying, well, we're only going to pay for bypass heart surgery under these circumstances. We're not going to pay for it other times. And there may be some other times when it is appropriate, but we just have to face it. We can't pay for everything and still get the money to go a long way. You have to ration some. I don't know if you're familiar with Oregon's health care plan, any? They have a plan?
Very little. I noticed, I have read where they had made some proposals of cutting down.
It will have some problems, but the basic thing they did do is they said, we have this much money, let's see how we can spend it most effectively, and said we will pay for these conditions. And they figure out, well, this is where our budget runs out. We can't pay below that. And they actually end up paying for more things than they would have without it. But they dropped some very expensive items that way. They didn't think that it was effective to spend their money on. They thought they could spend the money better in other ways. I think that approach of saying, we're going to have to be responsible here and actually look at how we're spending the money and make sure we spend it in a responsible way where we get the most health care benefits from it is the way they have to look at it.
Well, now, in Oregon, who determines that?
Well, in Oregon, it ended up being the legislature that did, but there were many, many physicians that worked for them with a whole lot of hours designing.
Yeah, but somebody had to come up with...
They ended up with
somebody
numbers.
had to come up with some regulation of some kind that would say we aren't going to pay for ex-service.
Yeah, it's the legislature. Of course, and it's talking about Medicaid. It's not what insurance companies do at their private body. With
Yeah, I know.
them.
It was Medicaid.
But it was a state legislature eventually did it. They numbered 1 through whatever, and I think they said we got enough money to pay through 528.
What you're getting at, same thing that John's talking about. Even in that state, there is a form of commission that's being given the authority to collect the data, to monitor it, to make sure that it's being carried out within the restrictions of the dollars that's been allocated. You know, in our business, we wouldn't be opposed to a set type of commission to that extent, because that commission within itself could do what Dr. Asriel was talking about. They could limit a certain amount of choice and guidelines as to the type of services that people could choose from and that sort of thing, which is not all bad, really, to a certain extent.
I think physicians groups particularly, though, have a lot of fear of a regulatory agency, particularly looking at prices. I mean, I think we sort of, like the horse racing commission, you know, we're not sure that they always end up, you know, being properly focused. And again, I'm not sure that, again, the price per service is the problem. I mean, I know that most of our medical organizations are really afraid of the idea of a regulatory commission overseeing fees and such. And I can understand that. It wouldn't bother me as much as I think it would bother the KMA. But I think it's sort of, you know, the government's not well known for price control and regulatory agencies, and we're not sure that would work real well.
You know, in one sense, we're kind of all working under a system of that nature anyway. It's kind of fragmented. It's not necessarily under one body now, but you've got maybe 2 or 3 different bodies between the private insurance companies and between Medicare and Medicaid that's basically working in that sort of direction with reimbursement. We're basically saying bring all those particular entities together, come up with something that's equitable and control it from that particular one central body, which, you know, we could live with that in our industry.
I believe the insurance companies are going to help a lot in what John's talking about. They're going to decide whether he likes it or not. They're going to decide what he can do and what he can't do, or what he's allowed to do. You know, eventually the insurance company's going to say, well, we're going to pay this much and that's all, and you can do so and so, but that's it. And it's going to, you know, the people are not going to be able to afford it, so they're going to have to stop with the insurance company. They're going to wind up making the decision for the doctors. I talked to an insurance company about a drug one time. It's been several years ago, you know, and it was an expensive drug. And I said, you know, they said, why did the doctor have to use it? I said, I don't know. You need to ask the doctor why he decided to use it. And I said, whatever he uses, you're just going to, you know, you have an agreement that you're going to pay for it. They said, oh no, says, eventually the insurance companies will educate the doctors on what to use. And they really love that. I've told that several times. But it's getting to be more like that. They're saying you have to call and ask and the doctors, if I'm right, John, you have to call a lot of times while you're in the doctor's office and say, can I go over to the emergency room, or not the emergency room, but outpatient for these type of x-rays. I know my insurance is that way, that I have to have it cleared before I can go over. And she can just say no, and there's not a thing you can do about it. Haven't you run into this, John?
Yeah, of course, we're not crazy about having more and more layers of hassles put in the way of things, but to some degree that may be necessary. I would like to see it simply cost you more to go have that done there than it would in the other way. And I think, you know, just things that cost more should cost the patient more. And
John's basically, Dr. Asriel's basically saying, you know, let's have choices, put dollar figures to them, and then you make the choice. You know, if you go here and get the service, your insurance company may pay for it, but if you go over here and get the service, they may only pay part of it and you have to pay a fee, or they may not pay any of it at all, whatever the circumstances may be, but still have a certain amount of freedom to make judgment calls about individual circumstances. And you know, even under that system, you got to have some type of, unfortunately, central agency that's got to have some controls over it.
I think it's a brief plug, I should say, that we probably do better than the rest of the country in this area.
Sure.
State, because we're one of the lowest cost areas in the
Well, I've even seen figures on that. I think you're absolutely right, and the public should appreciate that fact, and I believe they do.
Yeah, that's true in all health services. It doesn't matter whether it's in the drug stores or it's a doctor in long-term care, because I mean, all of us in our different professions, we have a pretty good idea of what prices are around the state with all the data that's collected, and there's no question long-term care is most inexpensive anywhere in the states right here in Glasgow.
I did a survey in the local newspaper not too long ago, and there was many $1,000
significant difference
between us and Bowling Green and Louisville.
And Louisville.
I'm sure if the average cost for sickness could be the same throughout the country for people as it is here, then President Clinton would probably be a happy person.
Yes.
Gentlemen, I thank you. Our time has expired. I thank you for coming, and you've been most informative. Thank you very much.
Thank you.
Well, thank you.